Care of the Aging Adult, Unit 2, Communication, Iowa Lakes Community College. This is Martha Olson. We will be discussing communication and how aging affects some of the communication with older adults, both sensory and cognitive, and also our therapeutic communication, including both verbal and nonverbal. Our objective is to look at the role of the nurse as we communicate with the older adults. Communication influences a person's independence, and spending time with the patient and allowing him to talk about life and emotions is important because a nurse would convey interest in knowing that older person, showing interest in caring about him rather than just caring for him. Our different communication methods are listed here, and they're all things that we can do on a daily basis. Limit the background noise. Many of our older adults, especially with hearing aids, get along much better in their room where one or two people come and visit with them rather than in a crowded activity room where there's a lot of noise and background noise that's very distracting when you wear a hearing aid. Trying to enunciate words, sit in front of them so they can lip read if they are hard of hearing. Cleaning their glasses is so important. Many of them are looking through glasses that are very spotted and filthy, and it's just a very nice, caring thing that a nurse does when they wash the glasses. When we communicate, we know a person is able to express how they're feeling, express what they need. They want a drink, they need to go to the bathroom. And then they also are able to convey their feelings about what's going on inside. So it's both cognitive and sensory that we are working with as we spend time allowing them to communicate with us. Some of the different areas of the brain that help with communication, we know the neuro and sensory units go together for all of the 5 senses that we have. The different parts of the brain have different areas for language centers and cognitive hearing, speech. And as we look at and review the anatomy and physiology, we know that strokes to different areas of the brain cause different problems that a person might have after a stroke. Both sensory and cognitive are listed here. Some of the changes that affect communication, with arthritis it might be gesturing, or after a stroke they're not able to gesture because they have some hemiplegia. Maybe the touch because they are a diabetic and they are poking the tips of their fingers to do the AccuCheck 4 times a day. As far as memory, thinking about dementia, some of the changes to the ability to remember long-term versus short-term, and then their ability to reason or organize their thoughts. So all of these work together. As we look at assistive technology, it's important that we know how to use the hearing aids and the different things that they might have that help improve their communication. Cleaning the hearing aids is very sensitive. They're about $5,000 a piece. And so taking good care of hearing aids is going to be very important. Many times people take them out at night and put them in a cup beside the bed that should be labeled hearing aids. You pull the hearing aid battery out so that it's not running all night, and then make sure you're changing and cleaning the hearing aids without getting them wet or causing damage to them. If you don't know how to take care of a hearing aid, many of the places that sell them or the audiologist will assist in getting the hearing aids fixed so that that person is able to hear and communicate in a much better way. When we look at some of our sensory alterations, it can be both sensory deficit, where they can't hear or can't communicate, but also overload. And like I said before, sometimes they get into rooms that are very noisy and very a lot of activity, and they just shut down. They just don't like that, and many times then they will just want to go to their room. So observing for that and helping to prevent sensory overload is going to be important. When we look at normal age-related changes versus pathological ones, that's important for a nurse to be able to know that, after age 40, sometimes the eyesight does diminish, but is it glaucoma? Is it maybe a retinal tear, something else going on that needs immediate medical attention? We know that vision is about 70% of the sensory information does come in through the eyes. We know that hearing, that nonverbal auditory information such as pitch. Many of your people that have vision problems use touch to help read or to help them communicate, and then smell and taste oftentimes diminish with aging, and you'll notice more older adults putting salt or a lot of spices on their food, trying to enhance the flavor because it just doesn't taste like it used to, is what many of them said. Among adults over age 70, visual impairments can have significant changes to their ability to communicate. When we look at vision, some of the normal changes, the lens can yellow, the lens flattens and becomes less flexible, and we see some mitosis with that. Some of the pathological changes that go along with the ability to communicate would be macular degeneration, diabetic retinopathy, your diabetic that loses their sight when their blood sugar is high and the very small retinal vessels are damaged with high blood sugars, your glaucoma or the pressure to the eyes, the cataract that has that kind of milky film over the eye. Cataracts can be removed. So of all the ones listed here, cataracts sometimes are an easier problem to fix. About 95% of adults over 65 report needing glasses to assist with their vision. Glasses are less effective in correcting vision with increasing age. We know that macular degeneration is the leading cause of blindness. The neurons in the center of the retina are damaged and causes blurred vision and loss of central vision. And on this slide, we're thinking of safety. If they don't see, they're going to trip and fall and have more safety issues related to that. For the diabetic with the retinopathy, remember the blood vessels leak in the eyes. New blood vessels form, but scar tissue forms along those new vessels, causing loss of sight. With the cataracts, that clouding, we know that cataract day at the hospital is often one where we have a lot in same-day surgery that come, have a cataract removed, and they are dismissed about 2 hours later. And then dry eyes, and many of them will just use eye drops to help keep the eyes well hydrated. Typical vision problems are loss of acuity or clarity to the eyes. The presbyopia is correctable with glasses as the vision is not focused on objects that are up close. And then as we look at the glare and light, many of your older adults will not drive at night because oncoming cars, the glare causes a lot of problems for them with driving. So many of your older adults identify this and will just make some lifestyle changes in relationship to those visual problems. Some of the cues that your patient might have some visual deficits, maybe they're under or overreaching, they're falling. For hearing, they don't react to loud noises, so when a door slams, they don't jump or show any sign that they even heard it. And then as I said, with the taste, sometimes their weight might decrease because they're not eating as much, it doesn't taste as good, or they add a lot of salt and we see hypertension as a result then. Some of our visual therapeutic communication techniques put things where they can see them. So if they don't see well out of their right eye because of a stroke, put things more to their left side. Try to label things. The phone should have big buttons, especially if they live at home or live in assisted living and would need to call 911 or to be able to even just use the phone to call their family. And then many of your books come in large print or audio books. As far as hearing, some of the normal changes that we see, earwax is very common. As a nurse working in the clinic, I can tell you that was one of the jobs that I learned to do in the clinic. I had never done it in the hospital setting. When you go to do that, make sure that the doctor has looked in the ears before. You don't want to irrigate in that ear if they would have a ruptured tympanic membrane because you would do a lot of damage. Tepid water, and then you always shoot the irrigant toward the roof of the ear, not toward the eardrum where you could damage it. As we look at conductive hearing loss, besides earwax, it could be a tumor, it could be otosclerosis, or hardening of some of the inner workings of the ear that cause that conductive hearing loss. Sensory neural is more due to loud noises. Some of the older farmers have maybe worked around loud machinery their whole life and it damages the auditory nerve, the cochlea. Could be pollution, ototoxic substances like taking high doses of aspirin, or maybe a nurse damaged the 8th cranial nerve when she gave Lasix IV push too quickly. There's many ototoxic drugs that we give on a regular basis, and we have to know what they are and do what we can to prevent causing loss of hearing because of ototoxicity. At age 50, most adults do start to lose sensitivity to pitch with high frequency. At first, background noises may not be understandable, and our risk factors in looking at that are cognitive decline, maybe a history of chronic otitis media, a child or a person that had a lot of ear infections, and years ago they didn't treat them or take them very seriously. Exposure to loud noise, people that like to go to rock concerts or, again, work around loud machinery. So there's a lot of things that can damage hearing. We know that most of it, a lot of it is normal hearing loss. Some of the pathological changes are pressure changes. You know, maybe they didn't fly in a plane during World War II that had a pressurized cabin and they punctured their eardrums. The tinnitus would be that long-term exposure to persistent ringing, buzzing, or roaring. Many of our chemicals are, again, ototoxic substances that we have. Aspirin, antibiotics, some of the antidepressants can even cause that. And the poisons listed in the book are lead and mercury that can cause ototoxicity. Typical hearing problems are not usually assessed by healthcare providers unless we notice that they are not responding. They may compensate by turning up the volume. When you go to an older adult's house and you can know what channel or what TV show they're watching on the television as you're knocking on the door, usually the volume on the television is up pretty high. They might be embarrassed, and so they just stay away from social events because they don't hear well, or they're miscued because they're missing some of the announcements. Patients typically do not report hearing loss. It might be the spouse that might indicate that George doesn't hear well. You have to repeat things several times. He does more lip reading if you stand in front of him. And then there would be some of those hearing therapeutic communication skills, not to shout. Males tend to get along better because they have a deeper voice. So if you're a female, if you can lower your voice a little bit, they do respond better to that. Allow them a lot of time to respond. Don't just keep repeating it, because they may be trying to figure out what they're going to respond back to you. And again, can you use other gestures, other forms of communication that might improve that? As we communicate with individuals that have visual impairments, you know, call out to them. I remember when I was working with a patient that had lost her vision, and she would like to work in the kitchen. That was where she felt very comfortable. But you had to announce yourself before you went into the kitchen because you would scare her. She couldn't see you and oftentimes didn't hear as well your footsteps. So you would just say, hey, what are you cooking? It looks good. Smells good. I can smell what you're cooking. And then everything was good. But if you scared them, then they got angry. Alert the person when you're coming in, or try to touch their arm or a very non-threatening place as a nonverbal gesture. As far as hearing impairments, again, a gentle touch, short sentences, maybe write things out for them is a very good way to help them communicate. So worth remembering, patients want to be cared for, but often they want more to be cared about. And so as we think about communicating with the elderly, it really is the essence of nursing. We will continue on then with part 2 of this PowerPoint.